So, very good morning, good evening, everyone. So, we are discussing about diuretics, right? So, in diuretics, the diuretics are those agents which will increase the urine output and excretion of sodium. We have discussed already, but there are a different types of diuretics which are depending upon the sites on the nephron. Some diuretics are acting on proximal convoluted tubules, some are acting on loop of annals, particularly ascending loop of annals. Then there is a distal convoluted tubule, some are acting on the collecting ducts. So we have already covered the diuretics which are acting on your proximal convoluted tubules, the drugs like acetazolamide on proximal convoluted tubules, there is a movement of sodium and hydrogen ions, right? So these particularly drugs which are carbonic anhydrase inhibitors, which are blocking it and doing the excretions of sodiums and bicarbonate. And if you remember, I told you these carbonic anhydrase inhibitor drug is acetazolamide. And these drugs are also useful, particularly carbonic anhydrase inhibitors are also useful in the glaucoma, and particularly it do the reductions of your aqueous humors, and you can use topically these carbonic anhydrase inhibitors. The drug which carbonic anhydrase inhibitors which we are using topically for the glaucoma is dorzolamide, right? So this is the topically availables for the glaucoma. And another important points about carbonic anhydrase inhibitor is if you see the structures of acetazolamide, which is a carbonic anhydrase inhibitors, it's a sulfonamide derivatives. Sulfonamide derivative. So it's a sulfonamide derivative. So when we covered the antibiotics, the sulfonamide could result in hypersensitivity reactions. Hypersensitivity reactions. So that could be the one of the adverse effect of your carbonic anhydrase inhibitors drugs. Another adverse effect can be your metabolic acidosis, right? And it can do the urinary alkalosis. And you know the reason why urine can become alkaline and why your blood can become acidic, right? Metabolic acidic when you are giving the carbonic anhydrase inhibitors. So you know already the mechanism why carbonic anhydrase inhibitor could result in metabolic acidosis and could result in urinary alkalosis, right? And another important point is these could also result in hypokalemia, and these we also discuss in details how what is the mechanism behind carbonic anhydrase induced hypokalemia, right? I'm not going in details. And so when you are making the urine, if your urine is become alkaline, then what will happen? Your acidic drugs can be excreted out, right? The reason is because when your urine is alkaline, your acidic drugs will remains in the ionized form and it's not going to reabsorb back. So, if you remember, when we talk about basics of pharmacology in pharmacokinetics, so you know that when if you want to reduce the toxicity of acidic drugs, you have to do the alkalization of the urine. And if you want to reduce the toxicity of basic drugs, you have to be acidify the urine. Why it is so? The reason is because when your environment in urine is alkaline, then acidic drugs will remain in ionized form. An ionized form of the drug is not going to easily reabsorb as compared to unionized form. So unionized form is going to reabsorb better. So your drugs will remain in the ionized form, so it will be excreted out, and vice versa. If your if your drug is basic, and you want to reduce its toxicity. So you want that basic drugs should be excreted out from the urine. So how it can be excreted out? The drug is basic, so you have to be acidify the urine. When you are acidifying the urine, your environment is acid, the drug basic is rich, so it will remain in the ionized form, and ionized form of the drug is not easily cross the cell membrane. It's not easily reabsorbed back to the systemic circulations, right? So this particularly carbonic anhydrase inhibitor, what they are doing? They are doing the alkalizations of the urine, right? So this is your carbonic anhydrase inhibitors, and if you remember in earlier video, I have discussed about these. If we talk about contraindications, these carbonic anhydrase inhibitors can precipitate the hepatic coma, right? And how it can be, because in liver disease, particularly liver, what they are doing, liver, your ammonia, NH3 is converted into uric acids, right? Urea or uric acids. So when there is a H positive ions are there before carbonic anhydrase inhibitors, so this ammonium ions will combine with the H positive and going to convert into ammonium ion and NH4 positive, right? So this NH4 positive can be easily excreted out because this is the ionized, this is the charged ions, and charged ions cannot easily reabsorb. But if you are giving the patient carbonic anhydrase inhibitor, so what will happen? H positive ions will be less here. So if H positive ions are less, ammonia will not convert into ammonium ions. And this ammonia is not charged, it's going to reabsorb back. And it can cross the blood-brain barrier and it could result in, can precipitate the hepatic coma. So this is the contraindications, right? So this is about your the diuretics which are acting here on the proximal convoluted tubule where your sodium and hydrogens are exchanged, right? So next one is your diuretics which are acting on the loop of Henle. So sometimes question will ask which part of the loop of Henle's loop diuretics acts on. So to answer to this question is it's acting on the ascending part of the loop of Henle's. This is the descending, this is the ascending, right? So ascending loop of Henle's, and that's why we also called it loop diuretics, right? Because these are acting on the loop of Henle's. So that's why we also called it loop diuretics. Got it? So loop diuretics, and what are the transporters in the loop of Henle's? You can see that there is a sodium, potassium, and 2 chloride, and this is the symporter. So I told you in earlier video there are a symporters. There are two terms, symporter and antiporter. So, so this one is your antiport. Sodium is going and hydrogen is excreted out. This the channels which is present on the proximal convoluted tubules. These are antiport systems. Why antiport systems? Sodium is going to reabsorb and your hydrogen is excreted in the luminal side. And this one is sodium, potassium 2 chloride. This is the symporter. Symporter means all the ions movements in the same directions. So they are going to reabsorb. So in the loop of Henle's, and particularly which part of the loop of Henle? Ascending loop of Henle's. There is a sodium. There is a sodium transporter, sodium, potassium, and 2 chloride symporter. Right? They are symporter means they are moving in the same directions. And where these are present, so on the luminal side. Luminal side. Okay. So, so it acts on the ascending loop of Henle's, and drug under this category, well-known drug is furosemide. Furosemide. There is a bumetanidine. There is a ethacyanonic acid. So these are all your loop diuretics. And loop diuretics, we also called it high ceiling diuretics. High ceiling diuretics, right? High ceiling diuretics. So maximum effects you will get. High ceiling right? High ceiling diuretics, and they are acting on this part, right? And again, means sodium is going to reach at your your distal tubules and exchanged with potassium and hydrogen. So again, these loop diuretics could also result in hypokalemia. So same mechanism which we have discussed with carbonic anhydrase inhibitor. Carbonic anhydrase inhibitors like acetazolamide also result in hypokalemia. Same mechanisms, these sodiums, these results in hypokalemia as well. Similar mechanisms. And but important thing is at equivalent doses, if you are giving the equivalent doses, you will get hypokalemia, less hypokalemia with loop diuretics as compared to thiazide diuretics. So you will get less if you compare hypokalemia than thiazide diuretics. And why it is so? Why it is so? Diuretics. Same reasons. Means, you can see the locations where loop diuretics are acting, it blocks here. And where thiazides diuretics are blocking it here in the distal tubules. So if it's blocking here, so there is a less chances for the potassium to reabsorb back. But here, potassium is again have a chance to reabsorb back much more as compared to thiazide diuretics. So that's why if you are giving the same doses of the loop diuretics or thiazide diuretics, you will get less hypokalemia with the loop diuretics as compared to thiazide diuretics. I hope it's clear. And of course, loop diuretics you will get in the prescriptions of if you want to remove the edema in congestive heart failures. You IV doses can be given, but it could result in hypercalcemia. Hypercalcemia. Loop diuretics can result in hypercalcemia. They can cause, excretions of calciums. So this is about your loop diuretics, and third one is your diuretics which are acting on distal convoluted tubule, and in distal convoluted tubule transporter is there. And what are the transporters? Transporters are your the sodium and chloride transporters. So thiazide diuretics like chlorothiazides, they are acting on sodium chloride symporter. So there are a symporter sodium chloride, and what are these? These are the symporter. And where these are present, symporter, they are present on distal convoluted tubule, DCT, distal convoluted tubules, thiazide diuretics, right? And thiazide diuretics are, best one, first choice for the hypertensions. And there is a diuretics which are acting here. These we call potassium sparing diuretics, right? And these are the diuretics which are acting on your last part of your distal convoluted tubules or on the collecting ducts. And there is a hormone aldosterone is also there. There is a sodium and hydrogen's antiport system is there, right? So these are your potassium sparing diuretics, right? Uh, Just 1 second. Yeah, sorry. So these are about your diuretics. The diuretics which are acting on the proximal convoluted tubules are your carbonic anhydrase inhibitors. Transporter is sodium and hydrogen antiport systems. The diuretics which are acting on the loop of anals and particularly ascending loop of anals, that symporter is there, sodium, potassium, 2 chloride. Then there is a thiazides, there is a sodium chloride symporters. Then there is a sodium and hydrogen antiport, sodium and hydrogen's potassium is also there. So these are the potassium sparing diuretics. So these diuretics are acting in the late distal parts and collecting duct. and these diuretics preserve the potassium, right? So they will retain the potassium if patient is hypokalemic. So you have to be prefer the potassium sparing diuretics, right? So there is a some sodium channel blockers. These some drugs can block the sodium channels, and drugs under that category is amiloride. So when we talk about these potassium sparing diuretics, so potassium sparing diuretics drugs are amiloride. Amiloride. There is a triamterene, triameterine. These are your, some sodium channel blockers and potassium sparing diuretics, right? Then there is a aldosterone antagonist. We have discussed aldosterone in detail when we talk about aldosterone. Renin-angiotensin-aldosterone system we have discussed many times. So aldosterone inhibitor. So what aldosterone is normally doing? Aldosterone will do the reabsorption of sodium and waters, right? So if you are if you are giving the inhibitor, so what will happen? So your reabsorption of sodium and water will not happen, and it will be excreted out. And that you want. That are your diuretics, right? So drugs, aldosterone antagonist is spironolactone, right? So spironolactones is your this one, but spironolactone problem can be it could results in gynecomastia, gynecomastia, and as well it could results in impotence in some individual if you are using for a longer period of times, and it could results in you know hyperkalemia instead of hypokalemia, right? Abdominal pain, peptic ulcer, these kind of things can be happens. So these particularly these are the potassium sparing diuretics, and they are acting on your late part of your distal convoluted tubules and in the collecting ducts. This is all about your diuretics, and in diuretics the important thing is why some diuretics results in hypokalemia, why the patient is more prone to hypokalemia, so which kind of diuretics you have to prefer. These are the reasoning questions which you can get, right? Why these means again carbonic anhydrase inhibitor results in hypokalemia, what is the possible mechanism behind it? Name the diuretics which are acting on ascending loop of Henel's, or in which part of the loop of Henel's these the diuretics acts, like furosemide, distal convoluted tubules, which diuretics acts, and what are the transporters on distal convoluted tubules, what are the transporters on your collecting ducts and later part of your distal convoluted tubules. So this is all important points about diuretics. So thank you. I'm going to stop.